Hello everyone. So today I will be presenting before you a procedure of hydrostatic reduction of intussusception which we did in our department under USG guidance. So it will be a good learning case. Just go through this whole presentation. So an 8-year-old male presented with abdominal pain for 24 hours to our institute, and after initial radiographs and USG, diagnosis of ileocolic intussusception was made. The patient was then referred from the pediatric surgery department for hydrostatic reduction of intussusception to our department. So before I say anything, I will just show you this video. Just go through it. There are multiple interesting signs that can be seen in a case of intussusception, and I would like all of you to go through this video. It is a 30-second time-lapse video with various loops stitched together during the procedure of hydrostatic reduction of the intussusception. So here you go. So you are seeing that there is an intussusception, and then we started the procedure, and you can see now the water surrounding the intussusception. And as the time passes, you can see the normal saline is now reducing the intussusception, and in the end it gets fully reduced. So what is the role of radiologist? So as a radiologist, we have to assess the patient from safety of procedure point of view. And to do that, we'll have to see these following, or we have to keep in mind these following 8 points. So the first is the general abdomen ultrasound findings. So apart from whatever visceral organ assessment we will do and the intussusception assessment, we need to find, or we need to see how the intussusception is as per. So outer hypoechoic ring of the intussusception is usually made from the everted segment of the intussusceptum and the flared up ends of the intussuscepiens. So this is the intussuscepiens and the intussusceptum. The inside of the intussusception could be made of only bowel, which could give us a donut sign, as in this particular diagram which is being seen in the ultrasound with a histopathological view. Or there could be an incursion of mesentery, which gives us a sign of crescent within the donut. There could be a leading point or a tumor or a lymph node or even a lipoma in cases of intussusception, which needs to be kept in mind. And this thing also needs to be evaluated if there is a leading point in a case of intussusception. So after assessing the intussusception or the intussusceptum and the intussuscepiens per se, we need to find if there is any free fluid in the abdomen, because free fluid will suggest if there is a possibility of bowel perforation, sorry. So second point is type of intussusception. In the type of intussusception, if we go from small bowel to the large bowel, there are 4 types, that is ileo-ileal, ileocolic, ileocolic, and colocolic. So one of the factors that affect the success rate, and we need to find and differentiate between ileocolic and ileo-ileocolic. Now it has been said that ileocolic one is a simple intussusception where the ileocecal junction has entered into the colon. However, in case of an ileocolic intussusception, there is a frond-like ileum that can be seen within the large bowel. It has been found that the reduction rate or hydrostatic reduction rate for ileocolic intussusception is approximately 10%, while that of only ileocolic is between the range of 80 to 95%. We have to also find out the cause, if there is any lesion or a leading point that can be evaluated, because then we have to send the patient for re-evaluation, clinical re-evaluation. I will show you that treatment algorithm in the last slide. We have to be aware of the time of the start of the symptoms, because this is also one of the factors which affects the success rate. If there is an acute and subacute type, then there are high chances, while in case of chronic cases, the chances of hydrostatic reduction decreases. There are other findings that need to be kept in mind. That is intussusception, that is a color Doppler, that is, and if there is any trapped fluid. So we have to assess the intussusception based and put color Doppler over it at the base, in the mid part, and in the apex. And we have to try to find out if there is color present in all the areas and in most of the intestine which is being evaluated, because that will suggest that there is not yet any gangrene that has set in. The pediatric surgery referral to be done always. Now we have to keep our pediatric surgery department in the loop. Even the anesthetist has to be kept in the loop, so that in case of any complication while doing hydrostatic reduction, the surgical team can be brought in. Now, the type of the fluid that should be used, and there are multiple fluids that can be used, like normal saline, Ringer lactate, Hartmann solution. However, in our institute, we used normal saline. There are case studies that suggest that Ringer lactate, being very much equivalent to the physiological aspect, is more useful for reduction. Sedation to be used or not. Now, sometimes a child can be in great pain, and it may be difficult for us to reduce it without sedation, or the patient could be really uncooperative. So in those cases, sedation can be used. However, we have to keep in mind that when we sedate the patient, the effect of the intra-abdominal increased pressure which the patient will put, or the Valsalva maneuver during the procedure which the patient will do, will decrease the intra-abdominal pressure per se. So the sedation reduces the intra-abdominal pressure which otherwise would have been put by the patient himself or herself. So after these points, coming to the technique involves placing the Foley's catheter in the rectum, and the bulb is to be inflated. The normal saline tubing is to be then attached, and the infusion is raised to a height of approximately 100 centimeters, which is approximately 80 to 85 millimeter column of mercury pressure. So sedation, as I already told you regarding it, and the pressure should vary from 60 to 120 mm of mercury, and 120 mm of Hg is approximately equivalent to 150 mm of column of water. So by this equation, you can just calculate that at 100 centimeters, what should be the height? Sorry, it should be 150 centimeters. So we can calculate accordingly. So now coming to the other signs which was seen in our case. Now I'll play the video again for you, and in this case you will find that we can find that there is an intussusception. This is the longitudinal aspect. We can see the intussusception. There is a thin incursion of the mesentery in our case. This was a type of ileocolic variety of intussusception. Then we are evaluating the intussusception in axial view, where we can see the donut sign, and as I go little bit back, we can see the crescent within the donut sign in our case. And then we started pushing in the normal saline. This is the normal saline that has started coming and started surrounding the intussusception, or the area of that intussusception. And then we can see we have to keep on evaluating in the longitudinal and the axial planes, and we can now see the ileocecal valve that is little bit swollen, and the intestine within. Still finding it that in spite the normal saline has surrounded the intussusception, there is still a little bit part which can be seen, and soon we realize that there is a reflux. You can see the fluid going into the terminal ileum. There was reflux of the fluid into the terminal ileum, and thus we completed the procedure of reduction. So coming to the last slide, this is one of the good articles from Radiographics stating various types of procedure that need to be done pertaining to reduction of intussusception and advantages and disadvantages of one over the other. Now we can do the hydrostatic reduction or the enema reduction under fluoroscopy, as well as there is another possibility of doing air enema. Then there is another possibility of ultrasound. So however, among all these procedures which the article discusses, ultrasound guided is one of the preferred due to absence of radiation involved and the ease of the real-time monitoring of the reduction happening, as we saw in our case, and also evaluation of complication. Like if there is a sudden loss of fluid surrounding the intussusception area, but there is sudden appearance of fluid in the abdomen or in the pouch of Douglas or in the pelvis, then it suggests that that there is a bowel perforation. So this article also gives us an algorithmic approach to be taken in case of intussusception, considering other imaging and clinical signs. So I'll just go through it for you once, that if there are any other pathological findings which we find in our initial ultrasound uh, scan, at that time, then we should not go for hydrostatic reduction, but we should go for clinical re-evaluation. Same is true if there is any lead point, like if there is a large lymph node, there is a large mass which is being seen. Intussusception in a very ill child, again, the child has to go under surgery. It's very difficult to do it is very difficult to do it under ultrasound guidance. Intussusception without trapped fluid or with flow at color Doppler ultrasound. So if everything is as per the planned thing, and as a radiologist, as I told you, those 8 points, if all those 8 points are within the normal limits, then enema or hydrostatic reduction with maximum pressure and maximum attempts can be done. If there is an intussusception with maximum trapped fluid or without any color flow at Doppler ultrasound, then enema with low pressures can be attempted with limited attempts. So again, if it is successful, then we just have to stop and reassure the patient. If it is not successful, then again, this, as I told you, the surgical team has to be kept on in the loop. So the patient has to be referred. So in our case, after successful procedure, we followed up the patient the next day on ultrasound, and there wasn't any recurrence. And after follow up on ultrasound, the patient was discharged with clinical advisory notes. So this completes almost the whole case of hydrostatic reduction of intussusception. I hope you must have liked it. And thank you for watching. As my resident says, keep tuned. Thank you.